This lecture is on skin cancer. This is part of the Year 4 Oncology Clinical Attachment. My name is Dr. Christina Mapiku. I'm a lecturer in oncology from the Blacktown Marjorie Clinical Campus. The learning objectives of this lecture is to review the epidemiology of skin cancer, particularly in Australia. Also look at the risk factors and known etiology of the different common skin cancers. I'll also be looking briefly at the anatomy of the skin and its structure. We'll then look into the different types of skin cancers, putting more focus in three of the most common types: the basal cell carcinoma, the squamous cell carcinoma, and melanoma. We'll briefly look at the pathology of these three, staging and grading, the prognostic factors, and the treatment options. The rates of skin cancer and melanoma in Australia and New Zealand are the highest in the world. We often looked at skin cancer as the non-melanoma skin cancers, which the most common being the basal cell carcinoma and the squamous cell carcinoma, and the melanoma skin cancers. In regard to the non-melanoma skin cancer, these are the most common type of cancer in Australia. About 1 in 2 Australians will be diagnosed with either a basal cell carcinoma or a squamous cell carcinoma in their lifetime. However, unlike other cancers, their incidence is not reported to the cancer registry. Therefore, incidence rates are often estimated. From the Cancer Council, there are approximately 434,000 treatments related to the non-melanoma skin cancer, and in 2008, there were approximately 543 deaths associated from them. On the other hand, melanoma has been reported to be Australia's national cancer. In 2012, more than 12,500 Australians were diagnosed with melanoma. Its incidence in Australia is the highest in the world, with about 63 men for every 100,000 and 40 women for every 100,000 have been diagnosed. The lifetime risk of developing a cutaneous melanoma by the age of 85 was 1 in 14 for males and 1 in 23 for females. It is the fourth commonest cancer behind prostate, breast, colon, and lung. It is the commonest cancer in the young people aged 15 to 24, making it a very important health issue. In 2012, over 1,500 people died from melanoma. In 2010, the lifetime risk of death from melanoma by the age of 85 was 1 in 85 for males and 1 in 226 in females. It is the 6th most common cause of death in men and the 10th in females. In regards to risk factors and etiology of skin cancers, exposure to UV light is by far the most important risk factor for developing any skin cancer. The acute, short, intense exposure to UV light, particularly UVB, has been associated with the development of melanoma, whereas a chronic UVB exposure is linked to development of non-melanoma skin cancer. People who have fair skin, freckles, those who have poor tanning ability, having red hair, those who burn easily, they've been described as having a skin cancer phenotype and has an increased risk of developing skin cancers. Being chronically immunosuppressed, whether as part of a hematological disease such as a chronic lymphocytic leukemia, being on immunosuppressants after an organ transplant, those on long-term steroids, and patients with HIV has a higher risk of developing skin cancers. More likely to develop squamous cell carcinoma, they tend to be of younger age, they're likely to develop multiple lesions, and these lesions tend to be more aggressive and more likely to recur. chronic immunosuppression also increases the risk of developing melanoma. Skin that has chronic trauma and irritation, such as those with ulcers and scars, has also been associated with increased squamous cell carcinoma, as does certain viruses, in particular the human papillomavirus, and the development of squamous cell carcinoma. Exposure to ionizing radiation, whether environmental or therapeutic, increases the risk, as does having a history of previous skin cancers. Any patient who has a previous skin cancer has a much higher risk of developing a new skin cancer in comparison to the rest of the population. Certain genetic disorders have been associated with development of skin tumors. For the non-melanoma skin cancer, xeroderma pigmentosa, which is an autosomal recessive disorder where there is a defect in the ability of repairing DNA as a result to UV light damage. Patients with this condition has an increased risk of developing both the non-melanoma and melanoma skin cancer. Patients that have a Gorlin syndrome, which is a rare autosomal dominant disorder, has an increased risk of developing basal cell carcinoma. In these patients, they tend to develop basal cell carcinomas at a younger age. Albinism has also been associated with development of non-melanoma skin cancer. Not surprisingly, the lack of pigmentation leads to increased DNA damage from UV light. For melanoma, having a family history of melanoma increases the risk of developing skin cancers. Approximately 5 to 10% of melanomas are related to a familial cause. Patients that have a giant congenital nevi, particularly if it's greater than 20 centimeters or affects 5% of the total body area, they have a much higher risk of developing melanoma. Melanoma in these patients tend to occur at an early childhood, by the age of 10 years. Looking at the anatomy of the skin can be divided into three main layers. There's the epidermis, the dermis, and the hypodermis. The epidermis is the most superficial layer and is separated from the underlying dermis by a basement membrane. The epidermis is made up of keratinocytes, from which squamous cell carcinoma originates from, the basal cells, which abuts the basement membrane, from which the basal cell carcinoma comes from, and the melanocytes, which is located in the deepest layer of the epidermis, which can transform to malignant melanoma. The presence of tumor cells originating from the epidermis into the underlying dermis is characteristic of invasive phenotype. The underlying dermis is made up of connective tissue such as collagen and houses the hair follicles, the sweat glands, sebaceous glands, lymphatic and blood vessels. Finally, the hypodermis is the deepest layer of the skin and is primarily made up of subcutaneous fat. There are different types of skin tumors depending on where they come from, the epidermis and the dermis. So the epidermal skin tumors are the squamous cell carcinoma, the basal cell carcinoma, melanoma, Bowen's disease, lentigo maligna, and the Merkel cell carcinoma. They all arise from cells within the epidermis, whereas the others, such as lymphoma, malignant fibrous histiocytoma, kaposiosarcoma, they all arise from the dermis. In this talk, we'll mainly be talking about the tumors that arise from the epidermis. The most common types of adult skin tumors that we will be focusing on are the basal cell carcinoma, the cutaneous squamous cell carcinoma, and the melanoma. Basal cell carcinoma is the most common type of skin cancer. It's a non-melanocytic skin cancer. As I mentioned, it arises from the basal cell that lines the basement membrane. It tends to occur mainly in the head and neck, with more than half of it occurring there, the trunk, the upper limbs, and the lower limbs. It is characteristically in appearance, can have waxy papules with a central depression. It is usually pearly in appearance. There's usually erosion or ulceration, which is often central and pigmented. There are telangiectasias over the surface, which can lead to bleeding, particularly when traumatized. In large basal cell carcinomas, these can ooze and be crusted. It's translucent and has a rolled, raised border. Basal cell carcinomas tend to be slow growing at about 0.5 centimeters every 1 to 2 years. It is locally invasive and very destructive, however, it rarely metastasizes. There are 5 main subtypes of basal cell carcinoma. There's the nodular basal cell carcinoma, which is the most common. They tend to be cystic, pigmented, and keratotic, and they typically present as a round, pearly, flesh-colored papule with telangiectasias and ulcerations. There's the infiltrative type, where it infiltrates the dermis in thin strands and sometimes make the margins less clinically apparent. There's also the micronodular. They don't tend to ulcerate. They appear yellow-white, particularly when stretched. They're firm to touch and its border is very well defined. The micronodular basal cell carcinoma tend to be aggressive, as does the morpheoform one or sclerosing BCC. They occur in about 10% of the BCCs. They're scar-like in appearance. They rarely ulcerate. They tend to be flat or slightly depressed. And there's the superficial BCCs, which tend to look quite red and erythematous. They're well circumscribed. They mainly occur in the upper trunk or shoulders, and particularly in younger people. They grow very slowly, and unlike the infiltrative or the sclerosing BCCs, they do not tend to be invasive. Patients with a BCC present with a skin lesion, and these skin lesions need to have a biopsy, which confirms the diagnosis. It's either a shave biopsy or a punch biopsy. They're often differentiated into either the undifferentiated type or the differentiated types. The undifferentiated types tend to be the worst of the two, tend to be more higher grade. Staging is not usually performed for BCCs, particularly because it's mainly confined to the skin. However, if there are larger lesions, they are staged in the same way as any non-melanoma skin cancers are staged, and using the TNM system, the TNM being the tumor, node, and metastasis system. Briefly, the T1 are lesions that are less than 2 centimeters in diameter. T2 are those greater than 2 centimeters in diameter. T3 involves invasion of the bone, such as the maxilla, mandible, orbit, or temporal bone, while T4 involves invasion of the skeleton or the perineural invasion of the skull base. And obviously, it's involvement of lymph nodes, while M is involved in the metastasis. And again, basal cell carcinoma very rarely metastasizes. They are locally invasive and destructive. What are the poor prognostic features for basal cell carcinoma? Although most patients are cured with surgery, certain features are associated with poor prognosis. Having a recurrent tumor is one of them. Having an incomplete excision leads to about a 30% recurrence rate. BCCs that involve the face, the ears, the genitalia, digits, hands, or leg, which are difficult to excise, have a poor prognosis. The micronodular subtype, infiltrating subtypes, and morphoic subtypes are also more invasive and aggressive. Finally, having perineural invasion leads to a poor prognosis. With regards to management, surgical excision is the primary treatment, and if excised completely, leads to a cure. However, most BCCs, because you need UV light as a risk factor, most patients who develop BCCs develop other BCCs. Radiation therapy can also be an option, as BCCs are usually radiosensitive. However, radiation therapy is used in patients with advanced and extended lesions, where surgery would be difficult, as well as those in whom surgery is not suitable. And for superficial BCCs, topical 5-fluorouracil can also be used as treatment. The squamous cell carcinoma is the second most common non-melanoma skin cancer. It clinically presents with shallow ulcer with heaped up edges, often covered with a plaque. It most commonly presents in the head and neck in men and in the upper limbs, followed by head and neck in females. And clinically, there's segment scaling, ulceration, and crusting. It's a malignant transformation of normal epidermal keratinocytes, and a functional loss of TP53 is likely a critical and early pathogenic event. Squamous cell carcinoma often arises from precursor lesions. Two being most common ones are the squamous cell carcinoma in situ, CIS, also known as Bowen disease. Bowen disease is characterized by a distinctive erythematous patch or plaque. And it's mainly characterized also histologically with involvement of nuclear atypia throughout the full thickness of the epidermis. The other precursor lesion is the actinic or solar keratosis, which involves only nuclear atypia in the epidermal basal layer. There's often variable hyperkeratosis or parakeratosis, and there's usually evidence of dermal solar damage or elastosis. In contrast with Bowen disease, it's usually found in non-sun exposed skin. It's often not fatal, but it can cause significant morbidity. It's most common in the head and neck, where surgery for advanced stage disease can be disfiguring. Invasive cutaneous SCC is characterized by invasion of the basement membrane by malignant-looking cells. So the precursor lesions are found within the epidermis, whereas they become malignant or invasive when they break through the basement membrane. You get nests of atypical cells found within the dermis, and this is often surrounded by an inflammatory infiltrate. As with most skin cancers, people present with a skin lesion, and they need to be diagnosed with a biopsy, which needs to be full thickness and should include transition point between normal and involved skin. Following the biopsy and a diagnosis of a squamous cell carcinoma, then we need to do imaging, usually with a CT scan for bone and soft tissue invasion or lymph node involvement, and an MRI, which is better for imaging perineural invasion and orbital or intracranial extension. This is to stage disease. In terms of the histology, squamous cell carcinoma is graded into well differentiated, moderately differentiated, or poorly differentiated SCC. The well differentiated SCC has a more normal appearing nuclei, where you still has abundant cytoplasm and the evidence of extracellular keratin pearls. They look more like skin. Whereas the poorly differentiated squamous cell carcinoma, you have a high degree of nuclear atypia, lots of mitosis in dividing cells. The nucleus is big with greater nuclear cytoplasmic ratio, and there's less evidence of keratinization. Moderately differentiated squamous cell carcinoma is somewhere in between the well and poorly differentiated cases. With regards to staging, similar to BCC, it's a TNM staging. And the reason we stage is it helps us prognosticate and decide on treatments. The early stage disease have an overall survival, 5-year survival of greater than 90%, so they do quite well if it's stage 1, stage 2. However, the most advanced stages, stage 3 and 4, it's only about a 25 to 45% 5-year survival rate. In terms of prognostic factors, we can divide this into tumor factors or extrinsic factors. Poor prognostic factors are associated with increased risk of recurrence or increased risk of metastases. So tumor factors, there's the location, so tumors, SCCs that are found in the lips, the eyelids, ears, anogenital region, or within a scar of chronic wounds, have a higher risk of developing recurrence or metastases. Tumors that are greater than 2 centimeters have up to a 33% metastatic rate. In contrast, tumors that are less than 2 centimeters have a less than 10% metastatic rate. The increasing depth of invasion increases the risk of nodal mets and local recurrence. So depth of involvement of greater than 9 millimeters or subcutaneous fat invasion increases the risk of mets and recurrence. Tumors that are less than 2 millimeters in depth has a 95% survival rate. Poorly differentiated tumors have a recurrence rate of up to 33 to 54%. Having an incomplete excision also portends a worse outcome with a recurrence rate of greater than 50%. Perineural involvement increases the metastases of up to 47%, and having a recurrent tumor also has a poor prognosis. Extrinsic factors that leads to a worse outcome, those who are really have a chronic immune suppressive state. So those who had organ transplantation, those who had a hematological malignancy leading to an immunosuppressed state, being on long-term immune suppression such as steroids, patients that has HIV and AIDS. Again, the risk of metastases in squamous cell carcinoma is rare. However, when it does, it tends to metastasize to the regional lymph nodes, which is often removed surgery. When it does metastasize in a distant organ, the most common being lung, followed by liver, bone, and brain. Again, distant metastases are uncommon for SCCs. In terms of treatment, again, surgical excision is the gold standard, and you need to have an excision of about a 4 to 6 millimeter clear margin. Radiation therapy can be used either an adjuvant in addition to surgical excision or a primary treatment. primary treatment using radiation therapy is often in patients unable to have surgery, and post-op radiation is used for improved local regional control in tumors that has perineural invasion, high-risk features, and those that have regional metastases, particularly the regional lymph nodes. Chemotherapy is reserved for those that have stage 4 metastatic disease. They tend to be platinum-based, and they don't actually work particularly well. So even with chemotherapy, patients that has distant metastases from a squamous cell carcinoma have poor survival. Melanoma is the malignant transformation of melanocytes. It tends to have a superficial or radial growth phase, so that's a flat phase, followed by a vertical growth phase where it grows down into the layer of the skin. It can present either as a primary disease or a secondary melanoma or metastatic melanoma. Patients who present with primary melanoma present with a skin lesion, so a pigmented multicolored skin lesion with a recent change in either the size, the shape, or the color. There are 4 main clinical subtypes of primary melanoma. The most common being superficial spreading melanoma. About 75% of melanomas are of this subtype. It is characterized by an initial flat face that shows changes in size, shape, or color. Superficial spreading melanoma is associated with relatively small amounts of UV light exposure and linked with intermittent exposure and sunburns. The nodular melanoma occurs in 15% of cases. They account for a majority of the thick melanomas. It is characterized by an extensive vertical growth with very minimal radial components. They tend to be symmetrical, raised and firm, uniformly colored, with bleeding and crusting. Lentigo maligna melanoma occurs in about 10 to 15% of the cases. It has an initial prolonged flat face. It presents with atypical pigmentation of a macule that changes. Lentigo maligna melanoma is associated with large cumulative doses of UV light and occurs in sun-exposed areas. Finally, the acral lentiginous melanoma in less than 5% of the cases. These are the melanomas that occur in the palms and the soles. And it's the most common type of melanoma in dark-skinned people. Also, melanoma can present once it's spread, and melanoma can metastasize to virtually any site, but in order, most commonly it can metastasize to another part of the skin, to the lung, to the liver, bone, brain, gut, the adrenal glands, and the nerves. However, most metastases are asymptomatic, and if they do present, they present with the involved organ, symptoms associated with the involved organ. For example, most commonly they present with fatigue and tiredness and weight loss as systemic features of metastatic disease. They can present with a cough if the lungs are involved, with jaundice if the liver has metastases. They can have pathological fractures if there's bony metastases, neurological disturbances if the brain or the nerves are involved, bowel obstruction and GI bleed if there's involvement in the gut. Patients presenting with a primary melanoma presents with a skin lesion, and there's particular clinical features to skin lesions that I would suggest that it's melanoma. These clinical features has an easy way of remembering them by thinking about A, B, C, D, and A. So A, for asymmetry, melanomas tend to be asymmetric. They have border irregularities. Their color changes. Their diameter, they tend to be more than 5 millimeters. And finally, there's E for evolution. There's a change in the appearance, the size, or the color, or elevation when it starts from the flat face to the vertical growth phase where it develops thickness. For diagnosis, one needs to do an excision biopsy for any lesions suspicious for melanoma, and it needs to be a full thickness biopsy, mainly because the most important prognostic indicator for the early stage melanoma, stage 1 and 2 tumors, is the thickness of the involvement. Depending on the location, and if resection will not result in a disfiguring defect, an excisional biopsy really should be done. However, if a lesion is large or if it's in an area where removal of skin will cause disfigurement, then an incisional biopsy may be performed. However, a shave biopsy, unlike in BCCs, is not good enough. Now, when looking at the pathology, certain things that are looked at when you get a pathology report, it will talk about Brenslow's thickness, which is used to describe the thickness, and it's also used for the staging. So tumors that are less than 1 millimeter thickness are thin tumors. Those that are 1 to 4 millimeters are moderate tumors. Those that are thicker than 4 millimeters are thick tumors. So the thicker the tumor, the worse it is. Look at the presence of ulceration. It's used for melanoma staging, and also it will report mitotic rate. Again, important for staging and prognostication. Usually, melanoma biopsies, immunohistochemistry is done. Certain things that they look for are S100, which is very specific for a melanoma. Other stains that are also used are the HMB45, Melan A, and more importantly, the BRAF mutation, to help triage those that needs genetic testing. And we'll talk about BRAF mutation later on. When someone has a melanoma, certain things that we also look for, a blood test using the lactate dehydrogenase, LDH, can be used as a tumor marker, and staging CT scans for anyone that has a full thickness melanoma. So CT scan, MRI, and whole body bone scan. Staging of melanoma, as with all other cancers, follows the TNM classification. So T for tumor, N for lymph node, M for metastases. The T depends on the thickness of the tumor. So we're looking at the Brenslow's thickness, less than 1 millimeter, 1 to 2 millimeters, 2 to 4 millimeters, or greater than 4 millimeters. We also look at whether there's ulceration or mitotic, also the mitotic rate. So a high mitotic rate, presence of ulceration, portends for a worse prognosis tumor. In terms of the lymph node, presence of regional lymph node involvement, and also metastases for the M. So stage 1 disease, the ones that has less than 2 millimeters of tumor. Stage 2 disease are those that have up to 2 to 4 millimeters of tumor. Both stage 1 and 2 do not have any lymph node involvement. Stage 3 disease are anyone that has lymph node involvement. And stage 4 disease are anyone that has metastases. There are certain features that portend of poor prognosis. So we look at the tumor thickness. Obviously, the thicker the tumor, the worse the outcome is. There's higher risk of recurrence, higher chance of developing metastases, involvement of lymph nodes or metastases to other organs are often associated with a poor outcome. Higher number of involved lymph nodes also has a higher rate of recurrence or metastases. Involvement of the trunk or the face has a higher, poorer outcome compared to involvement of the extremities. Ulceration in melanoma is also a poor prognostic factor, as is being a male gender. In terms of survival rates, melanoma that is diagnosed at a very early stage has a good prognosis. about 90 to 95% survival rate in those that have stage 1 disease after surgery. Those that have stage 2 disease has a variable outcome. It can be anywhere between 40 to 85% 5-year survival rate. It really depends on whether, when they do a central lymph node, whether the lymph nodes are involved. Because involvement of lymph nodes actually portends a poor outcome. As you can see in stage 3 disease, there's a 45% 5-year survival rate, whereas those that have metastases has the worst outcome with only a 10% 5-year survival rate. In terms of treatment for primary melanoma, surgery really is the main treatment. So it's not only diagnostic, it's potentially curative in those that has early stage disease, and we will be aiming for about a 2 centimeter margin in terms of surgical excision. Lymph node sampling may be required, either a sentinel node biopsy or a dissection. Adjuvant therapy in the form of radiation or systemic treatment is aimed to reduce recurrence, but it hasn't really been shown to improve survival. So radiation reduces the risk of local recurrence, and it's offered in patients that have nodes greater than 3 centimeters involved, those that has more than 3 positive lymph nodes, and those that have extracapsular spread are often offered post-operative radiation. Systemic adjuvant therapy, again, has been given to try and reduce recurrence, and it's offered in patients that have stage 2C, 3B, and 3C disease. At this stage, interferon alpha 2B, high-dose interferon alpha 2B is the only treatment that has been approved for adjuvant therapy for melanoma. Again, it's been shown to reduce recurrence, however, it has yet to be shown to improve overall survival. Treatment for metastatic melanoma really looks at systemic treatment. So prior to 2010, all we had was chemotherapy in the form of dacarbazine and fludarabine, and it wasn't particularly good treatment. It had about a response rate of about 10% and an improvement in survival of just over a month. So it was really quite dire back then. Since then, we've had an explosion in the different treatments, very good treatments for metastatic melanoma, so such as targeted therapy and immunotherapy. In terms of targeted therapy, at this point it's only really available for patients that have a BRAF mutated melanoma, and I will talk about BRAF mutation next. So there's 2 main types. So there's the BRAF inhibitors, being the brafenib and vemurafenib, which targets melanoma that has a V600E mutation, so in particular the most common mutation. The brafenib is the only one available on the PBS, but both have been approved by the TGA. And then there's the MEK inhibitors, which also targets the same pathway, and again I will describe about that in the next slide. Trametinib is the one that's currently approved, and it's been used both as a monotherapy and in a combination of either BRAF inhibition or immunotherapy. Next, systemic treatment are the immunotherapies, and there's 2 main types for metastatic melanoma. There's the anti-CTLA-4 antibody, or the ipilimumab. Anti-PD-1 antibody is the next one. There's 2 currently approved, pembrolizumab and nivolumab. Chemotherapy I've just put in there, but really at this point, really looking at them for historical reason. Targeted therapy only works for those that have a BRAF mutation, whereas immunotherapy can occur both in those that have a BRAF mutation and those that are BRAF wild type. Radiation also plays a role in metastatic melanoma, but really mainly for palliative reasons, for, let's say, bony metastases or brain lesions, so in symptomatic management. Surgery is also an option for metastatic melanoma in terms of removal of not only the primary but mainly the metastases. So not only does it provide good palliation and symptomatic control, removal of metastatic lesions can also improve survival. So usually patients with brain lesions, depending on the number and where they are, neurosurgeons can go in and perform surgery and remove the metastases, and this has led to better outcomes. Similarly, lesions in the gut or in the lung can be removed by surgery, even in the metastatic setting. To further understand the role of BRAF inhibition, we'll talk about the MAP kinase pathway in melanoma. The mitogen activated protein, or the MAP kinase pathway, is an important driver in the development of melanoma. In about half of the cutaneous melanoma, there is an activating mutation in the BRAF gene, particularly a V600E mutation, that causes the disease, leading to a constitutively active BRAF. Continually active BRAF leads to an activated MEK, activating ERK, and an uncontrolled cell proliferation. An activated BRAF mutation has been associated with high-risk features such as truncal primary, earlier age of onset, lack of chronic skin damage, and shortened survival. And so since 2010, and Australia has played a big role in the clinical trials that shows BRAF inhibitors efficacy in melanoma. What we do know about BRAF inhibitors is they have a rapid onset of response. However, melanoma tends to become resistant in about a year. Other ways to try and counteract the development of resistance has been to target the proteins downstream to BRAF, such as MEK, with MEK inhibitors. So we've had studies looking at combination BRAF and MEK. However, at this point, combination treatment has still not been approved on the PBS, but it is currently in clinical trials, and it shows that combination BRAF MEK is better than monotherapy alone. Currently, melanoma is the poster child for immunotherapy in cancer, and this is illustrated by the use of ipilimumab and PD-1 blockade, which is currently being used in other tumor types. So looking at ipilimumab, CTLA-4 blockade. So ipilimumab is a fully humanized monoclonal antibody which blocks the cytotoxic T lymphocyte-associated antigen 4. So T cell activation needs two signals usually. First is by antigen presentation by the MHC on the antigen presenting cells to the T cell receptor. The second signal then is the interaction of B7 on the antigen presenting cell with CD28 on the T cells. So when B7 and CD28 interact, this results to an activated T cell. When T cell is activated as a form of sort of self-control, CTLA-4 is then upregulated and binds competitively to B7 to turn off T cell activation. CTLA-4 is present on immune cells and aims to negatively regulate the T cells. Ipilimumab then blocks this inhibitory signal, which then leads to the activation of T cell and amplifies the T cell mediated immunity, which is part of the intrinsic anti-tumor response. The other method of immunotherapy is that of PD-1 blockade. So PD-1, or programmed death ligand 1, is a key inhibitory receptor found on activated T cells and also B cells. PD-1 is on T cells, and when it binds PDL1, or programmed death ligand 1, or programmed death ligand 2, this turns off the T cell activation. A number of tumors express PDL1, hence allowing it to escape the T cell response. PD-1 antibodies such as pembrolizumab and nivolumab then blocks this inhibition, allowing T cell response against tumor. So what we've covered in this lecture today is the epidemiology and risk factors of the different types of skin cancers, focusing particularly on the common type of skin cancers, the non-melanoma skin cancers, BCC and SCC, and melanoma. We've looked at the clinical features, the method of diagnosis, the staging and the pathology. We've briefly looked at the different prognostic factors and prognosis based on stage and the different treatment options. If you have any questions regarding this particular lecture, please feel free to email me. Thank you.